Hello viewers, welcome to the another episode of Physio TV. Myself Dr. Nupur Zadav, Assistant Professor at Electrotherapy and Electrodiagnostic Department at Sanjita Institute of Orthopaedic and Rehabilitation College of Physiotherapy. Today, I am going to cover the topic Biomechanics of Wrist Complex. Okay, the objective of today's session is to understand the anatomy of wrist joint, the kinetics and kinematics of wrist joint, anatomy of hand, kinetics and kinematics of hand, and prehension. Now we will be learning joint mechanics in terms of types of joint, articulation, degree of freedom, supporting structure to the wrist joint, kinematics and kinetics, and stability given by a structure to a joint. Now, why are we learning wrist joint? Now, if we see, shoulder joint provides a base for support of your arm movements, whereas your elbow joint adjusts the distance between your shoulder and wrist joint, whereas your wrist joint helps to hold an object in your hand so that you get a functionality. The function of wrist joint main function is to control the length tension in the hand muscle, fine adjustment of grip, designed for balance and control and not maximizing the torque. Means there are n number of muscles which are originating from an elbow joint and get inserts in the hand or to an IP and DIP and PIP joint. Whereas your wrist joint is a joint through which all the tendons and muscles are passing. So it helps in control. So those muscles are your multi-joint or two-joint muscles. So wrist joint provide a control for a length tension in your muscles, long muscles. Then it helps you to hold an object of different shape as well as different counters. So fine adjustment for your grips and even in prehension kind of thing. Now, as no major muscle bulk is present around the wrist joint, it helps in balance and controlling the muscle torque, but not torque production. So how is it going to balance and control? That we are going to see later. Now, why is wrist joint so complex? Because wrist joint anatomy is complex. Secondly, it has a complex biomechanics. And from each individual to individual, it has a lots of variation. And even smaller structural change will give you lots of difference in the function. So even smaller structure abnormality will affect your function. Now let's look at the anatomy and function of wrist right now, and we will cover it in our next part. So wrist complex is made up of carpal joint, mid-carpal joint. So today I have got a wrist joint complex model. Now if you see bone towards the thumb side, long bone towards the thumb side is known as radius, and towards the little finger it is known as ulna. Whereas you have a carpal bone placed in between your phalange and radius ulna. So wrist joint complex is made up of radiocarpal joint and midcarpal joint. Now what is radiocarpal? This is the radius and this is a carpal bone, that is a proximal carpal bone. And this is the ulna. Now remember, ulna directly does not take a part in wrist joint. So this bone, if you see, there is no direct connection between your ulna and your carpal bone. Whereas it takes part indirectly in terms of TFCC, that is your triangular fibrocartilage complex. Now, what is triangular fibrocartilage complex and radioulnar disc? It is something that is placed between these three bones. So it comes from radius, ulna, and it gets connected to a carpal bone. So it is placed somewhere here. Now, since radius is connected to a proximal row of your carpal bone. Now, which are your proximal row? If you see towards the thumb, you have a scaphoid, then you have a lunate. So this bigger bone is your scaphoid, then you have a lunate, then you have a triquetrum, and on the triquetrum, you have a pisiform, the small bone. So pisiform does not take part in a wrist complex. So you have a radius, you have a proximal row, that is your scaphoid, lunate, triquetral, and then you have a radioulnar disc and TFCC. Now let's understand in them what is TFCC, that is triangular fibrocartilage complex. So TFCC is a stabilizing structure that consists of radioulnar disc and various fibrous attachments. So it is radioulnar disc with lots of other attachment. So it provides you the stability to distal radioulnar joint towards the wrist joint and function as an extension of distal radial at a wrist. So now let's focus into the diagram. So TFCC disc proper is an horizontal portion. Then you have a meniscus homolog in the wrist joint, which is towards your ulnar side and triquetrum. Then you have a, if you see a dorsal and volar radio-ulnar ligament. So this is a TFCC, which is attached to a various fibrous support, that is your dorsal distal radioulnar and volar distal radioulnar ligament. Then you have a sheet of extensor carpi ulnaris. Then you have ulno-lunate ligament and ulno-triquetral ligament here. And last but not the least is your ulnar collateral ligament, also known as ulnar joint capsule. So these are the component of your TFCC. Later on, again, it is divided into proximal or upper and lower lamina. So disc is attached to an upper and lower lamina. So what is your upper lamina? Is this upper lamina is made up of dorsal and volar radioulnar ligament that we have seen in previous slide. So this was upper lamina. Then what is lower lamina? Other than that two ligament, everything that is your ECU, that is extensor carpi ulnaris, triquetral hamate, and base of fifth metacarpal through ulnar collateral ligament. So this is a part of lower lamina. And meniscus homolog is a region of irregular connective tissue that is the part of your lower lamina. Now, let's see the biomechanical features that gives variation to wrist joint motion. Now, if you see the model, if I place this way, my ulnar styloid process is on a lower side to my radial styloid process. So if I pass a line, ulnar is slightly lowerly placed than your radial styloid process by 12 mm. By 12 mm. This gave the inclination for a radius. If you draw a vertical line from this to this and radial styloid process, it will give me the angle of inclination, which is average 23°, which is normal. Again, if I see into sagittal view, then my radius is volarly tilted. So if I see the plateau of my radius, it is volarly tilted this way. So this angle will give you slight volar, angle of slight volar. It is usually 11° on average. That's the reason, because of this incongruency or bony configuration, there's a greater range of flexion as compared to extension and greater range of ulnar deviation as compared to radial deviation. Now, there is a concept called as ulnar variance and its clinical implication. Now, as I mentioned earlier, my ulnar styloid process is always on a lower side than a radial styloid process, usually 11 to 12 mm. If my ulnar styloid process is on the level of a radial styloid process, it is known as positive ulnar variance. And if my ulnar is more shorter than my radius, that is maybe 11 to 12 mm shorter, then it is known as ulnar negative variance. Now, how does it helpful for us? So, clinical implication, if my ulnar is going to be greater in height as with our styloid process, now we have come to know there is a TFCC. So if the height is more, it is going to give me impingement of TFCC when I do ulnar deviation, or rather for any movement of wrist joint. So it is going to give me impingement of TFCC between ulnar and which it is a triquetral carpal bone. And if I have a negative variance, so there will be avascular necrosis, that is avascular necrosis of lunate. Now this is the lunate bone. So if there is a huge difference, there will be abnormal forces on my lunate. Now what is avascular necrosis? Avascular necrosis, that is the reduction in a blood supply to that specific carpal bone, and then nutrition will be affected. So this will give a avascular necrosis of lunate, also known as Kimbroug's disease. And usually, relative longer ulnar can be seen after distal and radius fracture. So in this, my radius goes down and my ulnar is relatively on the level of styloid process. Now, what are the supporting structure? The radiocarpal joint is stabilized by strong but somewhat loose joint capsule, capsular and intracapsular ligament, various ligaments and muscle that crosses the joint, which also contributes to midcarpal joint stability. Now let's look all the ligament in detail. So I'll look for the movement. If you see, this is flexion of wrist joint, this is extension of wrist joint. Now the plane, that is the movement in which flexion and extension is taking place, this plane is your sagittal plane, but coronal axis. So your flexion and extension takes place in sagittal plane and coronal axis, whereas your radial and ulnar deviation takes place in a frontal plane, but anterior posterior axis. So wrist joint is biaxial movement. Now, normal range of motion for wrist flexion is 0 to somewhat 65 to 85 degree. Extension will be little lesser because we have seen the bony configuration, that is due to angle of inclination, and volatile, that is extension is here 60 to 80 degrees, 0 to 60 or 80 degree. Ulnar deviation, it is 0 to 45 degree, and radial deviation is 0 to 15/20 degrees. So again, flexion is more than extension and ulnar deviation is more than radial deviation. Now, range of motion depends on ligament laxity, joint surface shape, and constraint effect of muscle. So all these three factors are going to affect your range of motion for wrist complex. Now, second part of first part of wrist complex was radiocarpal. Now, second part is mid-carpal joint. Now, what is mid-carpal? That is the proximal row of your carpal bone and distal row of your carpal bone. Now, let's revise the proximal row. This is your scaphoid, lunate, triquetrum, and small bone which is sitting is pisiform. Now from thumb, this will be a trapezium, trapezoid, a big bone capitate, and then you have an hamate with a hook. So let's revise. Proximal row is your scaphoid, lunate, green color is triquetrum and pisiform. Distal row of your carpal bone is starting from a thumb is trapezium, trapezoid, a bigger bone capitate, and hamate with a hook. Now, rather than studying a mid-carpal joint, it is a functional unit. If you see a distal carpal bone act as a one functional unit rather than acting as a one single carpal bone. So it possesses its own fibrous capsule and synovial lining, which helps them to provide a nutrition and maintain the continuity with each other, intercalated articulation, and some connection with your carpal metacarpal phalangeal joint. So it has a synovial lining with its own capsule. We are talking about mid-carpal joint. Now, if you see a wrist complex, it is little a complex configuration because if you see the pebble-shaped carpal, somewhere it is concave, somewhere it is convex. It is not purely convex or concave. Then it is a unified movement. So movement that takes place at a mid-carpal. So distal carpal row, as mentioned earlier, function as one single fixed unit during the wrist range of motion, which provides the stability and transfers lots of load. Then how is the load distribution? Usually, load distribution is scaphoid, trapezium, and trapezoid. So these three bones. Then scaphoid capitate, this two large bone, and then you have a lunate capitate, this connection, and triquetral and hamate towards the ulnar side. So we have pairing of scaphoid, trapezium, and trapezoid, scaphoid capitate, lunate capitate, and triquetral and hamate. So usually load is distributed according this four unit. And mobility contribution, distal row contribute 2 degrees of freedom to a wrist complex, allowing radial ulnar deviation, that is just side to side, and flexion and extension movement. Now, what is the function of mid-carpal with the radiocarpal? So now basically when you grasp the object, it has to have a firm configuration that can be achieved with an arch formation. So distal carpal row forms the foundation of both transverse arch and longitudinal arch. So if you see in wrist, we have two transverse arches, that is proximal transverse arch and one is distal transverse arch, and one you have one longitudinal arch. So in our hand, we have a transverse arch, two transverse arch, proximal and distal, and one longitudinal arch. Okay, so mid-carpal joint will serve in an arch formation, then movement complementary and stability with movement. Okay. Here we come to the end of part 1 of biomechanics of wrist joint. I would like to thank Dr. Parag Sancheti sir, Dr. Radha Bhattar ma'am, Mrs. Manisha Sangvi ma'am, and a team of OrthoTV for giving me an opportunity to talk on this episode. We'll see you in the next part. Thank you.